Bringing us up to the present, the Affordable Care Act of 2010 made important changes in health insurance coverage in the US, but it also kicked off some really critical experiments and new policies in delivery system and payment reform. These payment changes are intended to control the cost of care, to keep care affordable, as it were, in the US, both in the private sector and in the public sector. And we see, while the Affordable Care Act is clearly federal policy making, pushing forward, that private payers, state Medicaid agencies are following suit, driven by many of the same concerns around cost and quality. The federal legislation is quite broad and includes many examples of payment and delivery system reform. Just to name a few, I first want to note that some of these changes are experiments to be evaluated and potentially integrated into new programs, and other changes fundamentally change the way Medicare is paying for health care. In the first category, in terms of payment experiments, much of the focus has been on increasing bundled payment. So paying for broader episodes of care to include more services in a single payment, and also paying a global amount for an entire population. So that's the newest version of capitation payment, where the payment is really per person. It doesn't vary depending on the use of services. And so there are pilots that are labeled accountable care organization pilots, a couple of different options there, including a pediatric accountable care organization pilot that includes Medicaid agencies in the states. In terms of policy that will affect the way, and currently is affecting the way, Medicare pays providers across the board without the need to study it, there are some programs that include some of the global payment ideas in the experiments, as well, a shared savings program for accountable care organizations that I'll say a bit more about. But this again is the notion of identifying a single provider organization that can coordinate and manage all the care for a patient population. There are also new penalties and bonuses for hospitals, including a hospital readmission reduction program that has begun requiring that penalties be paid back from hospitals to Medicare based on having very high readmission rates. Likewise, Medicare is changing the way it pays physicians with regard to the quality and cost of care. The new physician value-based modifier program has gone into effect, where physicians in groups of 100 or more in Medicare are being rewarded for high quality and low cost. The direction of payment reform is really to move away from a volume-based fee-for-service system, as I've shown in this spectrum, from a system that is very unit-based towards a system that is much more global, with the general notion that if we have very fragmented payment, we will get very fragmented healthcare delivery. Complications frequently occur because of that fragmentation. So the model here is to try to be as global as possible to encourage good outcomes and total cost of care that is as low as possible given those good outcomes. Along this spectrum, I've described already the history of pay for performance in the US. You can think about that as really the first step towards more global payment reform. From there, US health policy also began thinking about penalties. I mentioned readmission reduction program. Those penalties are one example of payers leaving the basic payment system intact, but then adding some additional mechanisms for controlling the unintended consequences of that volume-based care. Moving to the right towards my integrated global payment world, we see mixed payment for primary care. There are some aspects of Medicare policy post-Accountable Affordable Care Act that are pushing for differences in primary care practices as well, and in particular the notion of the patient-centered medical home as an integrating force for healthcare, and alongside that, some additional payments for these primary care practices. I'm going to say a few more words about the last two boxes in my spectrum, episode-based or bundled payment, and accountable care organizations or global payment on the far right. So the Center for Medicare and Medicaid Innovation, the CMMI, was put into place by the Affordable Care Act, and it's running a set of pilots for bundled payment. And these bundled payment demonstrations, they vary. Some of them only include hospital and physician costs. Some of them include post-acute care, such as rehabilitation, home health care. And so they're all efforts to encourage coordination, encourage trade-offs in the delivery of care that lead to better outcomes for patients and lower costs for Medicare. Hundreds of institutions are participating in these pilots, and they can select which patients, which diagnoses they want to choose bundled payment for. The most popular diagnosis that bundled payment is being tried for these days is heart failure. Joint replacements are also a target of innovation by hospitals around bundled payment because of initiatives in particular to look at appropriate use of rehabilitation and other post-acute care services where there are opportunities to improve the outcomes for patients but also save money for Medicare. Finally, accountable care organizations are really one of the most important changes in the delivery system right now. Many experiments are underway, not only in Medicare, but in the private sector under a variety of labels. The general idea, however, is that first, that an organization will take responsibility for all of a patient's care and not only manage the total cost of those patients, but also manage quality of care for those patients with an eye towards improving coordination of care and also reducing redundancy and waste. So this map shows accountable care organizations in Medicare across the country. And you can see in the darker shaded states, these are states where accountable care organizations are very prevalent, where there are 30 or more organizations that are undertaking this new contracting model with Medicare with the goal of saving money and improving quality. These happen to be states where the cost of Medicare is high. And so that may be where the greatest opportunities are for accountable care organizations to generate innovation that finds ways to keep patients out of the hospital, save money from those reductions in complications, but also save money from reducing waste. These programs are being studied closely. Many important questions remain about exactly how the payment system should be designed for accountable care, but also what kinds of hospital and provider organizations will be best suited to delivering care under a global budget that maintains access to care and also improves the quality of care. In summary, the key issues around payment reform in the Post-Affordable Care Act era remain the same as they always have been, which is how do we move forward with increased access to health care that is universal and equitable, but also affordable, and at the same time that we can not only maintain but improve the quality of care, improve patient outcomes. All of this requires balancing of incentives, careful performance measurement of patient experience of care, and so these payment reforms, while some of them have relatively simple formulas for payment, they're very complex in terms of their requirements for organizational design, for information technology that makes sure that we can monitor patients, that we can flow information through from provider to provider. Pilots that are underway right now in Medicare will give us more information about what are the factors for success and failure in terms of these payment reforms. We're likely to see an increased evolution in this direction, not only in Medicare, but also in the private sector.